In this session, we are going to discuss the ABCDE approach in detail, in depth, about the condition affecting the airway, like anaphylaxis, trauma, breathing, tension pneumothorax, asthma, in circulation, like shock and severe bleeding, disability, hypoglycemia, seizure, and exposure. Patient with airway obstruction due to foreign body, they show the following signs. Sometimes you see visible secretion, vomitus, or foreign body. They will have abnormal sound from the airway, stridor, snoring, gargling. Patient with mental status, changes in mental status, sometimes the tongue can obstruct the airway, so you see these patients are comatose. And when airway obstructed, you see poor chest movement. Managing these patients, you have to do suction if there is secretions, fluid or blood. Remove any visible foreign body. Don't push further into the airway. If there is complete airway obstruction, then use the Heimlich maneuver, chest thrust or abdominal thrust or back blow. For obstruction due to the tongue in patient with coma, then you do head tilt chin lift if the patient has no evidence of trauma or C-spine injury, while those with trauma and suspected C-spine injury, you can do the jaw thrust. And when you open the airway, then you can place oropharyngeal or nasopharyngeal airway, and then you assess for further disposition. Airway obstruction due to burn. Burn can cause swelling in the airway plus the tongue and throat due to inhalation injury. Patient can with burn can show burn sign on the head and neck, burn nasal hair or soot, abnormal sound like gargling and snoring and stridor, and there is poor chest rise. All patients with burn should have receive oxygen. Then you do head tilt chin lift, depend if there is trauma or no, and then you place oropharyngeal or nasopharyngeal as appropriate, and you might need to do C-spine immobilization in case of trauma, and then you have to arrange for the appropriate disposition. Airway obstruction due to allergic reaction, anaphylaxis. This patient can show facial swelling plus mouth, lip and tongue swelling, difficulty in breathing. They can have a stridor and wheezes. You can see rash and hives in their skin. Usually they are tachycardic and hypotensive, and you can hear abnormal sound from the airway, stridor, snoring, gargling, and there is poor chest rise. These patients should be monitored closely because complete airway obstruction can happen. You need to give adrenaline and for airway obstruction and severe wheezes or shock. You have to give repeated doses of adrenaline. IV fluid are needed to improve the blood pressure. You need to reposition airway as needed, and you can sit the patient in the upright position. You need to give oxygen, and some of these patients might need intubation and tracheostomy. Airway obstruction due to trauma. Patient with head and neck injury might have airway obstruction due to expanding hematoma. Patient can show neck hematoma. They can have abnormal voice plus abnormal sound from airway, stridor, snoring, gargling, and there is a poor chest rise. If there is blood in the mouth, you can do suction and remove it. Open the airway with jaw thrust, because here there is trauma. You have to avoid head tilt chin lift. And patient with facial trauma is better to use oropharyngeal rather than the nasopharyngeal. And maintain spine immobilization, and then you have to get support and consultation from a trauma surgeon. It is very important for any abnormal airway sound like gargling or stridor, reassess the airway frequently, as partial obstruction might worsen to complete block in the airway quickly. Breathing condition, we will discuss here tension pneumothorax. Patient with tension pneumothorax, they have hypotension and difficulty in breathing. They can have distended neck veins, absent breath sound on the affected side, plus hyperresonant percussion note on the affected side, and may have tracheal shift away from the affected side. Note that any tension pneumothorax can go, any pneumothorax can go and progress to tension pneumothorax. These patients, they need high flow oxygen, they need IV fluid, they need immediate needle decompression, and you need to prepare them for chest tube. Large pleural effusion and hemothorax. Presence of fluid in the pleural space can compromise the lung from expansion. Patients have difficulty in breathing. There is decreased breath sounds on the affected side, plus dull percussion notes. With massive effusion, the trachea can be shifted to the other side. Oxygen, patient need high flow oxygen, and you need to do chest tube. Patient with asthma and COPD exacerbation. Patient can present with tachypnea, difficulty in breathing, wheezes, cough. They can use accessory muscle, and some of them they have history of asthma and COPD or allergies, and some of the COPD have history of smoking. These patients, they need oxygen to improve their saturation and salbutamol to improve the airway narrowing, plus steroids and other management. Patient with suspected opiate overdose. As we know, opiate like morphine and pethidine and heroin can suppress the respiratory center. Patient have bradypnea, slow respiratory rate, hypoxia, very small pupil, and sometimes they are comatose. Those patients, they need oxygen. You need to reverse the antidote with naloxone. You monitor closely because you might need to give repeated doses of naloxone. Some of them, they might need intubation and ventilation. Circulation condition, pulselessness. Those with absent pulse in cardiac arrest, there is no pulse, they are unconscious, not breathing. In this patient, you follow CPR protocol. Circulation conditions like shock. Shock lead to hypoperfusion. Usually, it is recognized by hypoperfusion of the brain, kidney, and skin. In the brain, it leads to altered mental state that can progress to coma. In the kidney, it is monitored by low urine output. In the skin, you see cold, clammy skin with prolonged capillary refill more than 3 seconds. Patients at the same time have sympathetic manifestation like tachycardia, tachypnea, sweaty due to sympathetic overflow. And in the mental status, you see dizziness, confusion, altered mental status, plus there is drop in the blood pressure and hypotension. These patients should keep them flat if tolerated, give them high flow oxygen, secure an IV line, give IV fluid, control any bleeding if there is obvious external bleeding, and also source control for other sources of bleeding. When we suspect sepsis, give antibiotic, and you have to consider other causes of shock. Circulation conditions like severe bleeding. If severe bleeding is not controlled, it can lead to shock. Large amount of blood can be lost in the chest, abdomen, pelvis, and in the thigh. Patient with massive bleeding and shock, usually they show the manifestation of altered mental status and cold, clammy extremities, sweaty, prolonged capillary refill, plus tachycardia, tachypnea, and hypotension. You can see external bleeding wound. You can see bruises around the umbilicus in case of internal bleeding. Some people will have hematemesis and melena. Ladies can have vaginal bleeding, and at the same time you can see pelvic or femoral fracture. Those with hemothorax, you have decreased breath sounds and dull percussion note. Patient need resuscitation and source control. You have to fix an IV line, you give IV fluid, and you consider giving blood product, and sometimes you might need to use inotropes. To control the bleeding, you can do splinting for femoral fracture, pelvic binder, and for external bleeding, you do compression, direct pressure, or wound packing, plus tourniquet for uncontrolled bleeding. Other sources of bleeding like vaginal bleeding and GI bleeding, it need specific intervention, and then you need to assess if it is done in your facility or you have to refer the patient. Pericardial tamponade, it can lead to shock. Patient can present with the classical manifestation of shock, which is obstructive shock. In addition, they have distended neck vein, muffled heart sounds, and distant heart sounds. And this can happen in a context of trauma. Patient need IV fluid, and it need drainage of the pericardial sac, and this need an expert intervention. Disability conditions: hypoglycemia. This can happen in patients known to be diabetic or those with severe infection and malaria. They present with altered mental status, sweating, diaphoresis, seizure. Usually blood sugar is low. Even if you cannot check the blood sugar and you are suspecting hypoglycemia, you have to treat. You have to give the patient source of glucose. If he's conscious, you give him oral glucose. Otherwise, you give IV glucose. Disability condition: raised intracranial pressure. This can happen in patients with trauma, those with intracranial bleeding or tumor. This patient can present with headache, seizure, convulsion, nausea, vomiting, altered mental status, unequal pupil, and sometimes weakness in one side. When raised intracranial pressure suspected, raise the head of the bed for 30 degrees. If there is trauma, stabilize the cervical spine. In this patient, when you are suspecting hypoglycemia, you have to check and treat. And if there is convulsion, you give benzodiazepine, and then you need to arrange for appropriateness of appropriate place for management. Disability conditions: seizure and convulsion. Active seizure usually manifests as repetitive movement, fixed gaze to one side, or alternating rhythmically. Patient not responding. Patient with recent seizure you can find bitten tongue, urinate on himself, known history of seizure, confusion gradually returning over minutes. For this patient, you have to prevent hypoxia or any injury, protect them from falls or dangerous object. Do not stick anything in the mouth. Do suction as needed. Give oxygen. Give glucose as needed. For active seizure, you need to give benzodiazepine, monitor breathing, and then in case of a pregnant lady, you can give magnesium sulfate. After that, if they are repeated seizures, then you consider giving phenytoin or Keppra. Exposure condition: snake bite. Sign and symptom: there could be history of snake bite. Bite mark may be seen. There will be edema, blistering of the skin, bruising, hypotension, paralysis, seizure, bleeding from wound. Management: limit the spread of venom and the effect on the body. Immobilize the extremity. Take picture of the snake and send it to the poison control. If possible, give IV fluid if there is sign of hypotension and shock. Monitor closely. Patient might go into anaphylaxis and airway obstruction, and look for finding or sign of shock. Consider antivenom and other supportive treatment. Remember, when doing and assessing an acutely ill patient, if you find problem with any of ABCDs, stop, correct the problem, then go back and begin the reassessment of ABCDE approach again. Immediately after we do the primary survey and we do the ABCD approach and we stabilize the patient, then we go to sample history. Sign and symptom: we try to get information from the patient and from the family or anyone who witnessed. Sign and symptom is very essential component in assessment. We would like to know the allergy. It is very important to prevent harm, to avoid giving a medication that cause significant allergic reaction to the patient. In addition, the condition could be related to an allergic reaction. We need to know patient medication, obtain full list and note of recent medication and any changes in the dose. Because the medication could be the cause of the current illness, it can affect our selection of other medication and sometimes it leads to modification of the dose. Past medical history may help in understanding current illness and change management of choice. The current illness could be a complication of the past medical history, or the past medical history could be a risk factor for subsequent illness. As we mentioned before, like diabetes could lead to acute myocardial infarction, at the same time is a risk factor for coronary artery disease. And diabetes itself can present with hypoglycemia and DKA. Last oral intake, note whether solid or liquid food was taken, presence of vomiting, and patient who get illness and choking while eating could have airway obstruction by food particle. And some intervention like intubation, it is better than in someone who's fasting. And events surrounding the current illness is very helpful in predicting what is going on. Disposition consideration: after we do an ABCD approach and fix the life-threatening condition, then we go to sample history, then we go to secondary survey. After that, we need to decide about disposition, if we are able to manage this patient in our facility, or we need to transfer and we need to give handover to another service. Good consideration for handover include brief identification of the patient. You should reveal patient name and his location or her location, relevant element of sample history, physical examination finding, record intervention given, suggested future care and plan of care, things you may be of concern should be revealed to the other team. In summary and take home, follow the order of A, airway; B, breathing; C, circulation; D, disability and exposure. In the airway, always remember cervical spine immobilization. Identify at-risk airway and try to monitor closely. Assess breathing and be prepared to give oxygen whenever needed. Assess circulation and resuscitate with fluid and control source of bleeding if there is accessible and obvious source. Assess disability and check for pupil, and always remember glucose as a cause of altered mental status. Expose the patient, maintain dignity, and keep the patient warm. And thank you, and see you in the next session.